Hello, everyone, and welcome to today's live broadcast, A New Paradigm for Buprenorphine Testing, presented by Dr. Judy Stone, Senior Technical Specialist, University of California, San Diego Health Center for Advanced Laboratory Medicine, Mass Spectrometry, Toxicology Laboratory. I'm Alexis Krause of Laboratories, and I'll be your moderator for today's event. Today's educational web seminar is brought to you by Laboratories and is made possible by an open educational grant from Agilent. Agilent has had no input in the selection of speakers, content, or mode of presentation. Now, let's get started. Before we begin, I would like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time you want during the presentation. To do so, simply type them into the Ask a Question box and click on the Send button. We'll answer as many questions as we have time for at the end of the presentation. Also, please notice that you will be viewing the presentation in the slide window. To enlarge the window, click on the arrows at the top right-hand corner of the slide window. If you have trouble seeing or hearing the presentation, please click on the Support tab found at the top right of the presentation window, or report your problem by clicking on the Answer Question box located on the far left of your screen. This presentation is educational and thus offers continuing education credits. Please click on the Continuing Education Credits tab located at the top right of the presentation window and follow the process to obtain your credits. I'd like to now introduce our presenter, Dr. Judy Stone. Dr. Judy Stone worked as a clinical laboratory scientist in San Jose, California, and then obtained her doctorate in clinical biochemistry at the University of Toronto. Her fellowship in clinical chemistry was at the University of Minnesota Hospital and Clinics. She has since served as Assistant Professor and Associate Director of Clinical Chemistry at the University of Connecticut Health Center, as Assistant Professor and Director of the Core, Immunology and Toxicology Laboratories at the University of Massachusetts Medical Center, and worked with Mass Spectrometry at Specialty Laboratories, San Francisco General Hospital, and Kaiser Regional Laboratories in Northern California. She is currently Senior Technical Specialist in the Clinical Mass Spectrometry Laboratory, Center for Advanced Laboratory Medicine, University of California, San Diego Health System. Her research interests are in mass spectrometry method development, validation, and automation for clinical toxicology and endocrinology. She is the faculty chair for the new 2009 edition of the AACC online certificate program using mass spectrometry in the clinical laboratory. She teaches with a team of colleagues a 2-day short course on Getting Started with Quantitative LC Tandem MS in the Diagnostic Laboratory at MS-ACL meetings in the U.S. and Europe. She is a member of AACC and ASMS and serves as Chair, Board of Editors for the Mass Spectrometry Feature Series, Clinical Laboratory News. Dr. Stone, you may now begin your presentation.
Thank you, Alexis, for that introduction. And I'd like to start out by also thanking Laboratories and Agilent for the opportunity to speak to you today about some of the work we've been doing with buprenorphine testing at UC San Diego. I have to start also by thanking my collaborators, Dr. Rob Fitzgerald, who's the director of the Toxicology Mass Spectrometry Laboratory here at UC San Diego, chiefly, Dr. Amadeo Pese, who's the director of Precision Toxicology, who first got us interested in testing for naloxone. Aga Satarska, who's our liaison with TCAN for the collaborations that we've done with them using the AC plate. Judy Tang, my colleague from Kaiser, who generously shared some de-identified specimens and results with us for comparative testing. And finally, Heather Tone, Josh Aiken, and Don Francisco, my colleagues here at the UC San Diego lab, who helped with the validation of the methods I'll be talking about, as well as most of the production testing that I'll be describing. So I've broken the presentation up into 3 parts today. First of all, why are we interested in buprenorphine at all when we're talking about testing with LC tandem mass spectrometry in the clinical laboratory? Next, we need to discuss some buprenorphine pharmacokinetics and understanding how to interpret the urine test results so that we know what's appropriate for designing methods and how to report them. And finally, the meat, if you like, of the presentation, which is the analytical chemistry for testing of free buprenorphine and metabolites at sub-nanogram per ml cutoffs using LC tandem mass spec. So why buprenorphine? You don't need to be a clinical chemist or toxicologist to know. You just need to read the newspaper every day that we have an opioid abuse epidemic in the United States as well as in other countries, typically called opioid use disorder. And opioid agonist therapy is one of the most effective means for treating that. So what is opioid agonist therapy? It's chronic administration of a long-acting, slow-onset opioid. In the United States, that would be methadone or buprenorphine. And the reason that this therapy is effective is that it relieves the withdrawal and craving that people who are abusing short-acting opiates like heroin or oxycodone or fentanyl experience most of the time. There's only, when people are using those types of drugs, really a smaller amount of the time that there's actually the rush or euphoria immediately after a dose, and you don't get that with a long-acting, slow-onset opioid like methadone or buprenorphine. So using this medication improves retention of patients in a treatment program, reduces the risk of infectious disease from injecting drugs, and criminal behavior in order to obtain drugs illicitly. So it's really the most effective treatment for opioid use disorder. There's a lot of studies to prove that. I've given you a couple of references there at the bottom. And usually it's combined with behavioral therapies and other types of psychosocial support. So methadone has been available for a long time. Buprenorphine, really since the 1990s, routinely used. At first, it was thought that buprenorphine was not as effective as methadone in treating opioid use disorder, but more recent studies, and particularly when there's an appropriately high dose, have shown that they have similar efficacy. And again, I have some references for you at the bottom of the screen. Buprenorphine does cost more than methadone for the medication itself, but I was interested to see a recent study, that's the second reference down at the bottom of the page, that if you look at the total cost of treating a patient, that they may be similar for buprenorphine versus methadone. Obviously, that depends on the setting in which care is delivered and how those costs are assessed, but I thought that that was an interesting finding. So one of the advantages to using buprenorphine in the U.S. in contrast to methadone is that they're what I've called easier regulatory access. What do I mean by that? Well, buprenorphine can be dispensed at a physician's office rather than having to have treatment at a methadone clinic. So if you had, say, a community that needed to be offering treatment for opioid use disorder, it would be much more regulatory burden and much more expensive to have to open a methadone clinic, whereas existing physician offices could provide treatment with buprenorphine. There's less stigma for people who could be going to the doctor's office for antihypertensive medication or for buprenorphine, whereas if they're going to a methadone clinic, that's a little more specific as to why they're there. But our problem is that we have too few doctors, at least in the United States, who are trained and certified to use buprenorphine, and there's insufficient funds for treatment. So even though there should be, access should be easier, in fact, we do have logistical barriers, and so we have insufficient number of patients being treated. So buprenorphine can be, is available as a prescription by itself or formulated with naloxone. Buprenorphine is a partial opioid agonist. It has relatively low sublingual bioavailability, but it has very low oral bioavailability. So that's why it's given either as a tablet or as a film, as shown there in the photo, because the sublingual bioavailability, although low, about 35%, is certainly better than the oral bioavailability. And there is a new formulation just recently out called Zubsolv, where the bioavailability has been increased to about 45%. So naloxone, again, as anybody reading the newspaper knows, is an opioid antagonist. So how can that be useful if we're trying to treat with an opioid agonist or partial agonist? Well, naloxone, if given under the tongue, sublingually, really has extremely low bioavailability, 2% or less in most studies. And so essentially, insufficient active drug gets delivered systemically in order for it to act as an antagonist. So the typical mixture would be a 4-to-1 ratio of buprenorphine to naloxone and a sublingual film or tablet. But if that is used parenterally, meaning if it's injected or snorted, it may indeed cause withdrawal in some, but although not all users. And that's because I'm showing you there a public health announcement about the dangers of snorting Suboxone, one of the mixtures of buprenorphine and naloxone that's available, because naloxone has much higher bioavailability if it's taken nasally. So how is this supposed to work? Just showing you here in a diagram, the idea would be that if the medication is taken as intended for therapeutic use sublingually, both the buprenorphine and the naloxone dissolve out of the film or tablet, but the naloxone essentially isn't delivered systemically because of the low bioavailability. Whereas the buprenorphine has sufficient systemic bioavailability to circulate to become bound to opioid receptors and to deliver the desired therapeutic effect. However, if the tablet or film is crushed up or dissolved in some manner so it can be injected or snorted, then there's much higher availability of the naloxone. And so systemically, it can bind to opioid receptors and block a potential buprenorphine effect that one might obtain from injection, that is the euphoric high that would be desired. So the idea behind a buprenorphine naloxone formulation is that it's going to deter diversion. So just to reiterate, the sublingual use is effective for opioid agonist therapy because we have predominantly a buprenorphine effect, whereas an insufflated or injected mixture of buprenorphine and naloxone would have primarily a naloxone effect that is antagonistic. It can elicit withdrawal and can prevent or minimize the euphoric high in a subset of circumstances. So the naloxone effect predominates. There are some limitations. The naloxone half-life is much shorter than that of buprenorphine, so that effect, the antagonist effect, can wear off while the buprenorphine is still around. That ratio of 1-to-4 may not be sufficient in all circumstances to block the buprenorphine agonist effect. And finally, the antagonist effect, that is inducing withdrawal, is somewhat dependent on what the status of the patient's opioid receptors were at the time that the antagonist of naloxone is administered. So if a patient was taking a light dose of heroin or oxycodone, let's say, they might go into withdrawal. If they've been taking buprenorphine chronically at a high dose, it would have less of effect. So the bottom line is, in public health studies, that it is effective to deter diversion, it's just not perfect. So we are talking about laboratory testing. How is that useful in the setting of buprenorphine administered to treat opioid use disorder? I like this statement from the U.S. SAMHSA advisory on sublingual and transmucosal buprenorphine for opioid use disorder. And they're reminding us that laboratory testing is only a tool and it shouldn't be relied on exclusively for clinical decision making. I think often those of us in the laboratory place too much emphasis on the actions that are going to be taken from urine toxicology. So it's good to remember that it's used in context. And as well, it's good for us to continue to inform clinicians when we interact with them on the limitations of urine toxicology, because urine concentrations can vary with the patient's hydration status. Is it concentrated or dilute? Of course, if they have impaired renal function, that's going to affect the ability to concentrate urine. And chiefly, when we're talking about buprenorphine, the interval between the last dose and the specimen collection time, that's always of interest. But in this context, the ratios of buprenorphine to metabolite and to naloxone are variable depending on if you take the urine sample an hour after the dose or 24 hours after the dose, and so that's important to consider. Another reason that testing could be helpful is around the issue of adulteration of urine samples with the buprenorphine naloxone film or tablet. So the goal, of course, is to try to mimic compliance if a patient has not been taking their dose, or if they diverted some of it, sold it, or given it to a friend. And so this is a quote from a reference that I have there at the bottom of the page that I would encourage anyone who has to interpret results to read. I think it's very useful and well written. It says, even though only a small number of patients were identified to have spiked their urine samples, quantitative testing may help to identify urine spiking during office-based opioid treatment with buprenorphine. So let's go on now and move to part 2, talking about metabolism and pharmacokinetics so that we can understand some of these statements about interpreting the urine drug results. Let's start with the structure. So there's the structure of buprenorphine. It's somewhat higher molecular weight than many of the other opioids that we test for, around 467. It's a synthetic. You can see that it has the basic morphinan ring structure that I'm showing you there in turquoise. And when buprenorphine is metabolized, it's N-dealkylated to norbuprenorphine, so you can see where that group is removed. There's the structure for naloxone at 327, a molecular weight much more similar to many of the other opioids that we test for. And all three of these compounds have a glucuronide group added at the 3 position as part of their hepatic metabolism. And that's of interest both in terms of how the drug is handled in the body as well as what we do with it analytically in a urine sample. The next thing that I want to mention is looking at some of the pharmacokinetic parameters from sublingual administration studies. This particular numbers that I'm showing you here comes from the FDA-approved Suboxone medication guide. And you can see that naloxone is listed as having an elimination half-life of about 6 hours. That's actually the longest that I've seen. If you look at other studies, it's as short as 1 to 3 hours. And you can see that norbuprenorphine has the longest elimination time, almost 10 times longer, 45 hours. And that's the one that I've seen the most variability for, sometimes extended out to 70 or even 100 hours. And buprenorphine is slightly shorter. So as I mentioned earlier, naloxone has a much shorter half-life than the other 2 compounds. If we're looking at metabolism and the issues of laboratory quantification, obviously we're going to be measuring some of the parent drug, but it turns out that it's really not the most predominant species. So as I mentioned, it's metabolized to norbuprenorphine as well as to buprenorphine glucuronide, and norbuprenorphine is metabolized to norbuprenorphine glucuronide. Naloxone is also N-dealkylated to nornaloxone, but we won't be mentioning that any further. Most of the metabolite that we'll be talking about is naloxone glucuronide. So these are of interest analytically because you'll hear or you'll see in a report that we talk about total naloxone or total buprenorphine. And what we mean by that is that the free components, that is the buprenorphine, norbuprenorphine, and naloxone, are relatively easily to analyze, but we need to cleave off the glucuronide from the glucuronide metabolites to make them easier to analyze. So we do that typically with an enzyme using a hydrolysis protocol during sample preparation, and then we're converting those former glucuronides back to the free drug. So when we're measuring total, it's the free plus the glucuronides that are now also free drugs. So we have one process for measuring both species. If we look at the relative concentrations in urine, and this is data from our work here at UCSD, so it's with sublingual dosing just of patients who are in treatment, norbuprenorphine glucuronide is the most abundant species in urine. Now, I should point out that we don't measure the glucuronide itself. We measure, as I just described, total norbuprenorphine and free, and then the difference between those two should be the glucuronide. Now, I've listed naloxone glucuronide as the second most abundant species, but in fact, in many samples, we see the concentrations are as high, if not higher. Again, this is for total minus the free as norbuprenorphine glucuronide. The buprenorphine glucuronide itself is actually a lower concentration, and lowest of all are the free concentrations. Free buprenorphine higher than buprenorphine itself, and free naloxone the lowest concentration. Now, I can see anybody who's familiar with this testing, or even if you just listen closely to what I've been saying, what do you mean that you have naloxone and naloxone glucuronide present in urine? What about what you just told us, that buprenorphine has this very low sublingual bioavailability? How are those two statements, how can you say that both of those things are true? So when I showed my boss this data, this was his comment, that it was like recent headlines of fake news or alternative facts. How could it be believable when all these years we assumed that there was no absorption of naloxone from a sublingual film? So when we first developed our methods and we were measuring only total, not free drug, we expected that in this cohort of 69 samples, that some from our institution that had been measured at our reference laboratory and some from other laboratories that had shared specimens with us, that all of the naloxone that we measured would be quite low, less than a cutoff of 10. We actually were able to achieve ultimately a cutoff of 5 nanograms per mil. So that's what we expected, but this is what we actually observed, which is only a few specimens with concentrations below the detection limit, and most of them with relatively high concentrations. Indeed, you can see that the most commonly encountered concentration was between 100 and 1,000. So what could be going on? Well, Dr. Pesce from Precision Toxicology had been generous enough to share 20 samples with us, and he had also described this phenomenon. So we thought, let's take his samples out of the mix and see if that was biasing what we saw. But again, we saw the same thing. So with only 49 samples, we saw a median value for total naloxone of 245 nanograms per mil. 49 isn't a very big cohort. So again, Dr. Pesce was generous enough to share his data with us for a much larger cohort of 44,000 samples, and they're seeing exactly the same thing. And their median value for total naloxone was 363 nanograms per mil. So what do we think is going on? Why is it that most people would say you would not detect any naloxone in urine when you have sublingual buprenorphine naloxone administration? Why are we seeing so much? Well, of course, one possibility could be analytical error. We had a reasonable correlation between our concentrations and those at Precision Toxicology, and since then, we've compared with a couple reference labs and again have reasonable agreement within 20 or 30%. So for the moment, we're going to rule out analytical error. Now, you could say that perhaps sample adulteration is more common than you think, but we actually ruled that out fairly quickly because, as I'll show you shortly, the relative concentrations of free and total naloxone, buprenorphine, and norbuprenorphine in an adulterated sample are quite different from those in a compliant sample. So it could be that really we have the wrong expectations for how this drug is being used for most patients. That is, perhaps it's the norm that almost everybody who's taking the medication sublingually also does some injection or snorts part of their dose, and that therefore they have higher naloxone concentrations, because remember, both of those ways to administer the drug does deliver higher naloxone. We don't really have any way of ruling that out with the information that we have, but we think instead that we have to at least consider that what it is that we have the wrong expectations for what I've called BNX, that's the joint buprenorphine naloxone preparation, for those pharmacokinetics. So let me show you that graphically. So here I'm representing someone taking their sublingual dose. Of course, there's buprenorphine there, but we're just going to focus on the naloxone. And that pink bar that I've labeled as tissue is just really the mucosal layer across which absorption has to occur. And so our expectation is always that we had no absorption of naloxone. But really, when we talk about bioavailability in pharmacokinetic studies, we're not just talking about absorption, we're talking about metabolism. So we're postulating that what may be happening is we do have minimal absorption of naloxone, but then relatively rapidly it's circulating systemically, it goes through the liver, and most of it is glucuronidated. But if we're measuring only free naloxone, then that other portion of the drug is invisible. However, if we were measuring naloxone glucuronide or total naloxone in plasma during those pharmacokinetic studies, our theory is that we would actually see that there's reasonably high concentrations. It's just not active drug, because once it has the glucuronide added, it's no longer going to act as an antagonist, as an opioid antagonist. I couldn't find any studies, they may be available, showing that this had been measured in plasma during pharmacokinetic studies of sublingual naloxone. There are some methods out there, so I think they've probably been done, but as far as I could tell, it's not been published. Of course, once the drug is being cleared renally, if we're looking only for free naloxone in urine, and our work shows this, there's very low concentrations, and what we measured mostly less than 5 nanograms per mil. But if you're measuring total naloxone by hydrolyzing the glucuronide, or if you measured naloxone glucuronide, you would see relatively high concentrations. So that's what we think is going on. And it's just good to remember that absorption is not the same thing as bioavailability. There is some supportive evidence for this hypothesis. One is that if you look at naloxone peak exposure in patients with severe hepatic impairment, and a couple of good studies have been done on this, you have much higher free naloxone concentrations, over 1,000% higher. So this is consistent with the idea that you have a high rate of glucuronidation under normal circumstances, and when that's impaired, when you have hepatic damage, you have higher free naloxone concentrations. Also, if you look at the concentrations that are measured in pharmacokinetic studies, this is for free naloxone with sublingual buprenorphine naloxone. That's an 8 to 8 milligram mix. You see, as expected, very low concentrations of free. But in the one study I could find where they developed and validated a method for naloxone glucuronide, this is oral rather than sublingual administration, and it's tilidine rather than buprenorphine. But it is naloxone, and actually a lower dose of naloxone, and they measured over 100-fold higher concentrations when they were measuring naloxone glucuronide. So we feel that that's consistent with our hypothesis that the drug is absorbed, but just rapidly glucuronidated and therefore inactivated. This is just to remind me that we're moving on to the next section, and that is talking a little bit about testing to detect sample adulteration. So one of the ways to do that is to look at absolute concentrations. From a study in which total buprenorphine was measured, and I've given you the reference there down at the bottom, they found that a threshold of 700 nanograms per mil offered the best accuracy for trying to discriminate between an adulterated and a non-adulterated specimen. So this would be that somebody, say, dips their buprenorphine naloxone film in the urine before handing the specimen over for testing. The second study is from Dr. Gwen McMillan and Dr. Stephanie Marin at ARUP Laboratories. They were testing free buprenorphine, so it's important to remember to distinguish free from total. And they found that a threshold of 100 nanograms per mil, particularly when there was low norbuprenorphine, was suspect of urine adulteration. So one also needs to look at the relative concentrations of buprenorphine to naloxone and metabolites. We'll look at that in a minute. And that, again, it's important to distinguish both in our reporting and when we're talking about it, whether we mean free or total or glucuronide when we're measuring these species. So looking at the ratios, the ratio of free norbuprenorphine to free buprenorphine was reported for 786 samples by the group at ARUP. And that ratio was called the metabolic ratio. Other people had coined that term and done this, reported these ratios for total measurement of drug. This is for samples. They divided their cohort into those with a free buprenorphine less than 100 nanograms per mil, and we saw that that metabolic ratio, the mean was about 36 and the median was 25, meaning that norbuprenorphine was a lot higher than the buprenorphine. In the second cohort, which was a much smaller number of samples, where the free buprenorphine was greater than 100 nanograms per mil, they found that that metabolic ratio was much lower, less than 1, with several subcategories there, but indicating that the much lower norbuprenorphine and higher buprenorphine concentrations. So again, I want to point out this is free, not total analytes. So this is showing you the typical profile that you would see in a sample. This is one of our samples tested at UCSD with free method. So the free norbuprenorphine is quite high, 250. The buprenorphine is much lower, 6.8. And in this case, we did detect a little free naloxone, 6. As I said before, our cutoff is 5, so many of the samples are less than 5. In contrast to that would be an adulterated sample. We've only seen one that is this obvious. And there we have very high buprenorphine concentrations, around 800. The naloxone is around 300. So this isn't quite a 4-to-1 ratio, but it's not so far off. And then only a tiny bit of norbuprenorphine. So this presumably comes from a patient who had been taking their drug and then missed several doses and adulterated the specimen with some of a buprenorphine naloxone preparation. So this really was emphasized for us when we tested this particular sample with both our free method and our total method. And what you can see is that we get almost exactly the same results, about 800 for the buprenorphine, around 300 for the naloxone, and almost the same results for the norbuprenorphine. So this essentially tells us that everything that's present in that sample is free. There's essentially no glucuronide. All right, so we have some background to understand what's present in the urine sample. Given that, what are some common cutoffs that are used for testing urine samples for patients that are being monitored for buprenorphine sublingual therapy? So I consulted colleagues in the literature and looked at the web pages for commercial reference labs, and the most common cutoffs are somewhere between 2 and 5 nanograms per mil for free or total buprenorphine and norbuprenorphine, or for the glucuronide. There was one lab that used a cutoff of 2 nanograms per mil for total naloxone, and one that uses a cutoff of 100 nanograms per mil for free naloxone. Now, there are methods in the literature that have validated quantitation limits that are much lower in the picogram per mil range for buprenorphine, norbuprenorphine, and the glucuronides. But to my knowledge, those are not used routinely for monitoring samples from patients in treatment. Most of the research that's been reported for patient cohorts is using those higher cutoffs that I described. All of these are using LC tandem mass spec for testing. So the take-home message is that you can expect that in compliant patients, the norbuprenorphine is going to be higher, much higher than the buprenorphine. The ratio of those two may be helpful if there's a question about compliance, and it's important to know whether that ratio has been measured with total or free methods. Glucuronides are also present in urine at much higher concentrations than the free drug. And so again, one needs to define what's being measured. And finally, that monitoring only free buprenorphine, norbuprenorphine, and naloxone does not seem to be in common use. So let's go on now and talk about the analytical chemistry of that analysis. This is all using positive mode electrospray ionization LC tandem mass spec. So what are the challenges of urine buprenorphine testing now that we have this background? Well, first of all, that if you measure with those cutoffs that I've just described of 2 to 5 nanograms per mil, if you're measuring only free drug, you're going to have false negatives. So one solution to that is to measure both the glucuronides themselves as well as the free species. So that gives you more and adequate information. You're not at the risk of a false negative, but it does mean that you have more measurand. So instead of 3 substances for which you have to create calibrators and quality control material and review peaks and track quality control, you have 6. So definitely more work, although it's also more information. So as we've described, the other solution would be to hydrolyze the glucuronides and then measure everything as free, because you have much higher concentrations once you've done that. However, norbuprenorphine glucuronide is notoriously resistant to enzymatic hydrolysis compared to the other opiates that we typically hydrolyze. And I've given you the classic reference down there at the bottom from Dr. El-Soli's lab describing those issues, typically taking much longer than other enzymatic protocols, say for morphine glucuronide. And so I would say as a result, what it means is that there's greater uncertainty surrounding total norbuprenorphine concentrations between different laboratories that use different hydrolysis protocols. We certainly found that our protocol, original protocol, was very vulnerable to a low pH or a high pH in samples, and we had to modify that to have a stronger buffer concentration, a better control of pH, so that we had more consistent hydrolysis between a range of patient samples. Furthermore, if you're interested in measuring naloxone and the glucuronide, They're quite polar, the glucuronide most of all, of course, and so they elute earlier in a reverse phase LC, and they ionize less well than buprenorphine or norbuprenorphine, so they're more challenging to measure at low concentrations. However, the free-only testing, it seems like it would be logistically easier if we could avoid the enzyme hydrolysis and we could measure only 3 compounds and not 6. Potentially, it would be easier testing, potentially better reproducibility, and certainly less expensive. So the question is, can we come up with sufficiently low cutoffs that free testing can be clinically useful? And so we decided to look at this by testing all of the clinical samples for patients in treatment that would be submitted with both validated free and total methods, using cutoffs for the free analytes of 0.2, 0.5, and 5 nanograms per ml. That's for the free buprenorphine, norbuprenorphine, and naloxone, respectively, and cutoffs of 5, 5, and 10 nanograms per ml for the total analytes. We also had some discussion with the primary clinician who uses our service for buprenorphine testing, and she was comfortable with the idea that we would define a compliance sample as positive for norbuprenorphine. So that would be at a cutoff of 0.5 nanograms per ml for free and of 5 nanograms per ml for total. And so even if the buprenorphine was negative, the patient would still be considered compliant so long as there was a positive norbuprenorphine. So we were interested in using the TCAN AC plate for free buprenorphine testing. We were doing some collaboration with TCAN around developing and validating methods using that extraction medium. If you're not familiar with it, there is a proprietary non-polar resin that's coated on the wells of 96 well format plates. I think that the easiest way to think about how this extraction works is that it's an immobilized liquid-liquid extraction. So your analytes are going to partition into that non-polar resin in the same manner that they would partition into, let's say, an immiscible organic phase like hexane ethyl acetate from your urine sample. But logistically, it's much easier. It's simple to automate. All you do is pipette and then put the plate is on an orbital shaker, so you don't have any flow through extraction medium. There's no centrifugation. There's no manual separation of a liquid-liquid layer. Although you can, after you elute from the resin into the wells of the plate, you can evaporate that and reconstitute it. Our goal was to have no evaporation and reconstitution step so that we could have 100% of the sample preparation being done on the deck, processed by the liquid handler. So this is the diagram that TCAN puts out on how this extraction works. The first step is to mix the sample with internal standard, typical for any extraction procedure for LCMS, and add some extraction buffers so that we have both the analyte in the matrix in an appropriate environment such that it's going to extract well into the resin. And that's done by 10 minutes of mixing on an orbital shaker. Then the pipette tips are used to throw away that extraction waste. And the next step would be to add a wash solution, so that's to remove residual matrix. And again, there's shaking typically for 5 minutes. Then the tips are used to throw away that waste. And finally, an elution reagent is added. So in some manner, we shifted the conditions, the organic solvent or the pH or both, such that the analyte comes back out of the resin into the liquid phase, again for 5 minutes of shaking. And then finally, TCAN recommends that you transfer that to an injection plate, although you don't have to. So compared to other extraction options, the advantages are that it's easy to automate. We only have one liquid handler, so we actually do this protocol. We have a manual backup procedure. You just have to be very careful about cross-contamination between wells. It has excellent reproducibility. I made mistakes while I was doing method validation, and it was quite forgiving. And finally, it had good detection limits for us. There's a low recovery, as you'll see in a few slides, but there's a proportionately greater decrease in noise, and we're able to successfully get rid of matrix, so you end up with an excellent signal-to-noise. Of course, there's always some disadvantages. There is less concentration that's possible if you're using a flow-through media, where anybody who does solid phase extraction knows you can put a very large volume through an SPE cartridge or plate. Whereas in this case, you're limited to a total volume in the well of 300 microliters, and that has to include your internal standard and your extraction buffer. Perhaps the biggest limitation in terms of the menu of compounds that can be tested with this technique is that it's applicable to nonpolar analytes. So they have to have a log P or log D, which is the pH-sensitive log P that's greater than 3 in order to be extracted. So let's take another look at our analyte chemistry. And you can see that we have these phenolic groups on all 3 of our analytes that at a high pH can become ionized and therefore make the molecule more polar. More importantly is the amino group that all of them have, and at a low pH that can become protonated, charged, and again affect the polarity. So we have to pay attention to both of these things when we're thinking about how we want to get this molecule in its most nonpolar state so that we can extract it. So if we look at the log P's for these 3 compounds, you can see that buprenorphine has a log P of almost 5, norbuprenorphine of 3.6, but naloxone is below that threshold that I mentioned earlier of 3. It's only 1.9. If you're not familiar with log P, it's just the number that's derived traditionally by putting the compound in an aqueous and mixing it with octanol and then measuring how it partitions and taking the log value of that. So obviously from buprenorphine to naloxone, we're talking about less to more polar. But what's interesting is the pH, if you like, lability of the polarity for this group of compounds. So as I mentioned earlier, the amino group, when it's protonated, has a major effect on the polarity. So we've got a 10-fold decrease. It's much more polar for buprenorphine, from 4.98 to 0.45. In contrast to that, the phenolic group has much less of effect on polarity, but I've given you the pKa's for all 3 of those compounds, both for the amine and for the phenol. And I just want to point out that it's important to remember that log P these days is more often calculated than it is measured. And so depending on which software is used, you're going to see quite different values for log P, depending on which source you consult. So the fact that there were those 2 pKa's, that potentially there might be an optimal pH where our molecules of interest were at their most nonpolar state, led me to think about this. So here the axis is pH, and what is the corresponding log D? So at low pH, it's acidic. We have a charge on the amine group. At high pH, it's basic. We have a charge on the phenol group. Is there something in the middle where we either have no charge or we have a Zwitter ion? What pH would that be, and what is the resulting log D? That was our question. So I felt quite proud of myself that I'd consulted the older medical literature back in the 60s and 70s about this. But as so often happens, somebody else had thought of it before. So in preparation for this webinar, I came across this reference from 1997, and Everhart and the group had published a method for sub-nanogram concentration measurement of buprenorphine and metabolites. This was using, this is before LCMS was in wide use, so it was using gas chromatography, but they also identified pH 9.1 as the optimal pH. So we looked at how well these compounds extracted. This was just in an aqueous low organic mixture at a pH of 6, 7, 8, 9, and 10, and then looked at the raw peak area. These are measurements in triplicate. And what you can see is that norbuprenorphine is drastically affected by the pH. Sorry, naloxone is drastically affected by the pH in terms of the extraction efficiency. Norbuprenorphine only a little bit here in the red, and the buprenorphine not very much at all. And so the optimal pH that we defined for extraction was 9.1, same thing as the earlier authors. So here's our extraction workflow using a TCAN Freedom EVO 100 liquid handler and the AC plate. The liquid handler adds 150 microliters of urine to a well of the AC plate, 25 microliters of internal standard, working internal standard. It's a deuterated internal standard for all 3 compounds. Mixes for 2 minutes. Then we add 125 microliters of a very strong ionic strength sodium bicarbonate, buffer it, pH 9.1. It's shaken on the orbital mixer for 10 minutes to extract. Waste is discarded, and then there's a wash step, maintaining the same pH but with a little bit of methanol to remove some matrix. And then finally, after the waste is discarded, an elution step, where we have 20% acetonitrile in water, but the important component here is the formic acid, which shifts the pH to less than 2. The compounds all become protonated and then partition out of the resin back into the liquid phase. We transfer it to an injection plate and inject 7 microliters on the LCMS. So I've given you the method parameters here, both for the hydrolysis and for the LCMS. I'm not going to spend any time on this. If you're interested, Laboratories can provide you with a PDF handout of the presentation, and you're also welcome. We're happy to share our SOP with anybody who'd be interested in implementing the method. Just send them an email, and we'll be able to provide you with the SOP. So, of course, one of the things we always worry about with LCMS is matrix effect, and this is showing you graphically an experiment of post-column infusion to evaluate. This is the 6th gradient that I looked at. We tried a 3-minute LC run, but we had too much matrix effect, so we had to lengthen that to 4 minutes. Here you can see for naloxone, these big negative deflections are showing us where we've lost signal due to co-eluting matrix, but we're free of that with this gradient at the time that naloxone elutes. For norbuprenorphine, this is for the total extraction procedure. You can see that it also looks good. We have big negative deflections, but they're on either side of our retention time for norbuprenorphine. And for buprenorphine, you can see it's pretty edgy, isn't it? There's this big negative deflection that we see for all samples, and the retention time for buprenorphine is just after that. So we expected that we might have problems with that, but in fact, this is showing you the same data, slightly different manner. This is for the free process. Again, you can see that naloxone is eluting away from ion suppression. Norbuprenorphine appears to be, although there's a little something here, isn't there? I'll come back to that. And finally, buprenorphine is once again right on the edge of a major area of ion suppression. However, what we found is in production, we don't really have problems with this in the samples that we encounter routinely. Whereas unfortunately with norbuprenorphine, we do have the occasional sample that has severe ion suppression, and so we have to dilute that times 10 with drug-free urine, and that for the most part gets rid of the ion suppression, but it is an extra step. And so probably the LC program could be improved to separate norbuprenorphine from this area of ion suppression. We just haven't bothered to do that so far. We also did quantitative matrix effect studies, and we had good hydrolysis recovery with low variance. If we look at the extraction recovery, as I mentioned, very low indeed for naloxone, and particularly only 7%, and the highest was for buprenorphine at 42%. However, we have good precision, slightly higher than the threshold that's published by the College of American Pathologists, where they say they should be less a 15% or less variance between samples. But you'll see in the next table that that is corrected with the internal standard. And the same thing for matrix effect. We have low variance between samples. This is spiking the drug at these 2 different concentrations into 10 different patient samples. A little more ion suppression for buprenorphine than we'd like to see. But as you can see, when we ratio the recovery of the analyte to the ratio of the deuterated internal standard, that's corrected completely, and we have better precision. And it's the same story for matrix effect. So ultimately, when we combine those 2 things, as those of you who do these studies routinely are familiar with, for what we call the process efficiency, we have good numbers, values around 100, and with precision less than 10% between samples. So as a chromatographer, we always have to show you peaks. This is naloxone, norbuprenorphine, and buprenorphine. This is the quantitative MRM trace at the lower limit of quantitation, so this is the cutoff. You can see that the peak shape is not ideal for naloxone or norbuprenorphine. It's much better for buprenorphine, which has a much greater response for the same concentration. But these were adequate. They all had a signal-to-noise greater than 10. Naloxone has the lowest signal. They all passed ion ratios within plus or minus 20%, and they all had at least 11 to 12 scans per week, the absolute minimum that you'd like to see for quantitation. So how precise is this protocol at such low concentrations and with kind of barely acceptable peak shape? Well, actually, it was reasonably good. This is a validation study for the free method. We tested a pool at 4 nanograms for naloxone, 4 nanograms per mil for naloxone, and 0.4 for norbuprenorphine and buprenorphine, and all had CVs less than 15%. And then for these 2 higher concentrations, CVs less than as you can see, 5 and 7%. Of course, it's always easy to be precise during validation. The question is, how well does the method work in production? And here's our numbers for the production QC from last November until this August. And you can see that for our low and high control at these concentrations, higher for naloxone and around 1.5 nanograms per mil and 75 nanograms per mil for free buprenorphine and norbuprenorphine, that our CVs are acceptable, less than 8%, less than 5%. So let's get back to our original question. What results did we get when we tested all 214 samples that come from patients who are in treatment with the free and total methods? And basically, the two techniques agreed. Remember, we have different cutoffs, of course. We have to have much lower cutoffs with the free method. And so we divided those into two categories. So the one, which was 92% of the samples, we had all the results agree. 87% of the samples, buprenorphine and norbuprenorphine, were positive with both methods. For only 3% did we actually have negative with both methods, and then we had a small number of samples, only 3, where the norbuprenorphine was positive and the buprenorphine was negative with both methods. We had this other set of samples where the norbuprenorphine results agree, and remember that's the criteria that we're using to evaluate a specimen as being from a compliant patient, but there was disagreement for the buprenorphine, and most of those were the case where the total method was positive for buprenorphine and the free method was negative. There was a small segment in the other category. So this is just a graph showing you a plot of those results. This is total naloxone on this axis, and you'll see that concentrations go up as high as almost 6,000 nanograms per mil, and this is the percent free for each of those samples, and you can see that the yield is actually very low, less than 2% free. And most of that is that most of these specimens, the concentration was below the detection limit, less than 5. So if we look at the same plot for total norbuprenorphine versus percent free, you can see that we have a higher percent free, around 20 to 30%, and that's what saves us essentially and allows us to use a cutoff of 0.5 nanograms per mil for the free method. And you can see again concentrations go as high as 4,000 nanograms per mil for the total. And finally, for buprenorphine, the same plot. This is we saw a percentage somewhere between 2 and 5% free for most of the samples that were measured for total and free buprenorphine. And in both of these plots, for the one for norbuprenorphine, sorry, the one for naloxone and the one for buprenorphine, I've omitted that one sample that I showed you earlier, and that was because there was essentially 100% of free buprenorphine and 100% of free naloxone, and so it would completely would bias the plot seriously if I included it. So in conclusion, we feel that free buprenorphine measured at a cutoff of 0.5 nanograms per mil can be used for monitoring compliance with buprenorphine therapy. The extraction is relatively simple and easy to automate. We would like to see studies at other centers to see if they have the same results. And finally, we still do offer the total buprenorphine and metabolite method on request, but we no longer do it by reflex. If we've had a few samples since we changed our policy that were negative completely with the free method, we actually ended up repeating them and doing the total just to reassure ourselves, and they were all congruent. So that concludes my presentation. I thank you for your attention. I'm happy to answer questions.
Thank you, Dr. Stone, for your informative presentation. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the Answer Question box located on the far left of your screen. We'll answer as many of your questions as we have time for. So let's get started. Our first question is, do you recommend that free buprenorphine testing replace testing with total buprenorphine or testing for free glucuronides?
I don't actually. I think that any one of these methods, whether it's free only, whether it's the total protocol that I would say is probably most commonly used at reference labs as well as academic medical centers that do this testing, or perhaps the one that provides the most information, the free plus glucuronide testing. I think any one of those can give answers. It's what's most appropriate at your site. There's such a burden for doing method validation and development. I don't know that many sites would want to replace their current protocol, but if you're new to this type of testing, I would encourage you to think about whether this might be suitable for you. It may require some additional consultation with your clinician so that they understand if they've been getting testing, say, with total, and now you're switching to free, but that's always a productive conversation to have anyway, regardless of what method you'll be testing with. So I just really, it sounds a little pretentious, the title of a new paradigm. What I probably should have said is a new option. It's another way that the testing can be done, and I'm happy to say that now, when we first talked about presenting this, we didn't have much experience with it, but we've been doing it for about 6 months now live, and we've had good success with it.
And it looks like our next question is, how well have the clinicians in your health system accepted this approach to buprenorphine monitoring?
So it was a pleasant surprise for us, and I think it just speaks to the excellence and the knowledge of the clinicians that we're dealing with, primarily one specialist in substance abuse treatment, that she is very open to looking at a different way of testing. We get in touch whenever we have a sample that's completely negative and ask if we should retest or should we do the total testing. And depending on the circumstances, sometimes we do one and sometimes do the other. But it was a really positive experience for us, and I would encourage you, to reach out if you're knowledgeable about the topic, not just about, of course, the testing part, but how it's being used by clinicians. I think that people will be open, and particularly if it means that you can get results with a faster turnaround time, or there's easier communication, let's say with the laboratory within your health system versus sending it out, I think there's definitely advantages.
Now, Dr. Stone, do you have any problems with matrix effect in the samples encountered with routine production testing?
Yeah, so as I mentioned, unfortunately, we do see some severe negative, some depression of the internal standard, therefore reflecting also depression of the analyte signal for free norbuprenorphine. We don't see that with naloxone or with buprenorphine. And as I said, our solution, which we validated, has been successful by diluting it. Luckily, these samples are positive, and they're quite positive. So our quantitation is fairly similar in those samples that we dilute and then do not see the matrix effect. But we still are performing the dilution. As I said, I think the long-term solution really would be to modify the LC gradient such that we move the norbuprenorphine away from that region of ion suppression that we see in, I would say, just a few samples. It may well be that those patients are all taking the same drug. We really haven't done the homework yet to say whether that's the case or not. But yes, we have encountered some ion suppression problems.
So we are getting so many good questions today, but it looks like we only have time for one more. So Dr. Stone, what do you use for collaborators and QC material?
So we make our own calibrators in drug-free urine, and we have purchased commercial QC. When we were doing the total protocol, we purchased it with norbuprenorphine glucuronide, buprenorphine glucuronide, and naloxone glucuronide in it so that we could QC our hydrolysis process. But now that our primary testing mode is just free, we're purchasing it with the free drug present, and that's worked well for us. We feel strongly that we don't like to make up both the QC and the calibrators ourselves. If we make up one, we'd like to purchase the other commercially so that we have a check on our accuracy.
Thank you again, Dr. Stone. Do you have any final comments for our audience?
I don't think so, other than that I hope that this presentation has been useful to you. And again, anybody who's interested in doing this type of testing, we're happy to share our SOP, which is, as anybody who knows me, incredibly detailed, and so potentially could allow you to get started with the testing. Just get in touch with Laboratories, and they'll act to connect us so that I can give you a copy of it. Thanks again for the opportunity to talk to you today.
Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Just a reminder, any questions we did not have time for today will be addressed by the speaker via the contact information you provided at the time of the registration. We would like to thank Laboratories and our educational sponsor, Agilent, for today's educational webcast. This webcast can be viewed on demand through March of 2019. Laboratories will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, goodbye.